Good morning, all. It is great privilege to be part of CardioCon 2025. After different talk regarding LDL cholesterol and then triglyceride, my task is to summarize the both talk in a form of the guideline. So why it is very important to have a Indian specific guideline, because the Indian having a different set of the lipid challenge. 72% of the patient having low HDL, 30% of the patient having high triglyceride level, and very few patient having a high LDL level. And our population developed the cardiovascular disease at the decade earlier than the Western population. So 50% of the coronary artery disease associated deaths in India occur before the age of the 50 years, and very high number of 25% of MI that is occur before age of the 40 years. So very earlier and malignant disease that's found in our Indian population. One of the unique problem in Indian or Asian is the high little lipoprotein A level, higher statin exposure. So patient having higher plasma level with the low dose of the statin, so the side effect is higher with the lower dose. Conventional risk calculator is underestimate the risk. So it is recommended to calculate the lifetime risk rather than the 10 years risk in Indian population. So the guideline came first in 2016. They came with the low, moderate, high, up to a very high risk group. Then in 2017, they came and targeted the special population, CKD, women, HIV. In 2020, they came with more aggressive goal and come out with the extreme risk A category and extreme risk B category with the LDL goal up to 30 milligram per deciliter. And they strengthen the recommendation to check for the ApoB and lipoprotein little a in every patient. In 2024, that is a consensus statement, and the three different things than the previous guideline. One, they give very more important to the subclinical atherosclerosis and elevated the risk up to similar to the patient having MI or stroke. They introduced the extreme risk category C, where the patient having a multiple cardiovascular event despite of the low LDL level. And family, also they give the family history of premature ASCVD as a directly the high risk group. So this is how Indian society classified the patient in different risk category. One of the major ASCVD risk factor is the age, then the current cigarette smoking or tobacco use, blood pressure, and the low HDL. Low HDL is very common in Indian population. The other high risk features is a family history, CKD, ApoB more than 130, lipoprotein more than 50 milligram, metabolic syndrome, non-alcoholic fatty liver is also directly in a high risk group, and coronary artery calcium between the 1 to 99. This is risk modifier. This is also very important, as the lipoprotein between 20 to 50, all metabolic syndrome, impaired glucose, high waist circumference, female specific like PCOD or premature menopause, and air pollution is also one of the risk factor, and the HIV. So any presence of any of this risk modifier directly jump the patient from low to moderate or moderate to high risk category. So any 0 or 1 major ASCVD risk factor, then patient in low risk, 2 or more risk factor, then in patient in moderate risk category, 3 or more risk factor, then in high risk category. Patient with diabetes with 0 or 1 risk factor in high risk category, and diabetes with target organ damage or more than or 2 major ASCVD risk factor directly goes into the very high risk factor. Similarly, in coronary artery calcium score, more than 100 is patient went into the very high risk category. This is very important extreme risk category. Patient with MI or stroke with the one or more features of the high risk group, then it is a category A. Patient with MI, stroke or peripheral vascular disease with more than or one features of very high risk group. Those who have recurrent ACS, polyvascular disease means simultaneously MI, IHD or peripheral vascular disease of the two territory in one patient, then it is directly goes into the extreme risk category B. And those who have recurrent disease despite of LDL of around 30 milligram per deciliter, then it goes into the special category C. So, in this current guideline, important is to detect the subclinical atherosclerosis by way of either carotid Doppler, femoral arterial Doppler, or coronary CT calcium score. So, detection of this carotid plaque, and it is significant when there is an intima medial thickness of more than or equal to 1.5 mm. You can identify the peripheral vascular disease by this ankle brachial index. So, quantification of the calcium over the CT scan is very important, and it is directly linked to the coronary atherosclerosis, except for the few cases where CKD or hyperparathyroidism, where there is a calcium deposition without atherosclerosis also. So, the clinically important is the once patient having any of this subclinical atherosclerosis evidence, their lipid goal is directly goes to, less than 50 milligram per deciliter. So, coronary calcium it is more than 100, or it is between 1 to 99, but it is higher than the corresponding age, sex or race. Any stenotic or non-stenotic carotid, coronary or femoral disease is also in very high risk group. So, detection of this is very important. And where we can recommend this assessment of the subclinical atherosclerosis. So, any patient in moderate or high risk group, family history of premature ASCVD, suspected or diagnosed familial hypercholesterolemia, individual with multiple ASCVD risk factor, or patient where they are not ready to take the statin, we can further reclassify the patient and emphasize for the statin if there is a associated carotid or other disease. Non-alcoholic fatty liver disease is also equivalent high risk group, and their target LDL is less than 70. Similarly, metabolic syndrome, we all know the diagnosis of metabolic syndrome, and that is also associated with 2 to 3-fold increased risk of the cardiovascular event, and where the target LDL goal is less than 70. There are many risk modifiers, as I already told earlier, that can reclassify the patient from one category to higher category, and that is the female specific risk factor. Then inflammatory disorder is one of the important risk modifier. Presence of SLE or spondyloarthropathy, rheumatoid arthritis, where there is an ongoing inflammation in body, constant activation of the immune system, taking NSAID, steroid, all these contribute to the higher atherosclerosis. So, one of the important, two important point is, one thing is the reassessment of the lipid parameters after 2 to 4 months of anti-inflammatory therapy, because initially with the active inflammation there is a pseudo low LDL cholesterol in this patient. And one of the important therapy to address this is colchicine is now 0.5 milligram twice a day is recommended in guideline to identify the or address the residual inflammatory risk. So, this is very important in patient after the LDL goal or ApoB goal, you can further address this residual risk with the colchicine. Hypertriglyceridemia is one of the important risk factors that already told by Dharmesh Solanki sir. So, after addressing the LDL goal, you have to address the triglyceride level also. So, in patient with the hypertriglyceride, rather than going for checking the lipid profile, ApoB is more important, even better than the non-HDL to identify the risk of particular patient. HIV is one of the risk modifier. Now there is a more prevalence of HIV in community, and statin is proven to reduce the risk in all these patients. One of the important trial, that is the REPRIVE trial, that shows the pitavastatin 4 milligram, it significantly reduced the MACE by almost 35%. So, treatment approach is low, moderate, it is 100 and 100. From high risk group and very high risk group, the target of LDL is 70. Extreme risk group A, target is 50. Extreme risk group B, its target is 30. And even in extreme risk category C, the target is 10 to 50 milligram per deciliter. Corresponding 30 milligram higher for non-HDL goal, and less than 65 ApoB for the high risk group, and less than 50 for the extreme risk category B. So, this is very important slide. After reclassified the patient, these are the goal.
जरा संभल के। अरे
this is the guideline.
थोड़ा और नीचे, और नीचे,
Now ezetimibe.
किशन
This is
प्लीज
risk
जरा देख
factor.
के।
अरे डिस्टर्ब मत करो ना। किशन भाई, हाँ, थोड़ा और नीचे, और नीचे।
So this is already one of the Hindi movie that's having guideline, Indian guideline. So overall lipid lowering therapy, if person's person's target is the 30% from the baseline, then start with the moderate intensity statin therapy. If our goal to reduce the 50%, then start with the high intensity statin therapy. If our goal is to reduce 65%, then use the combination of the high dose statin plus ezetimibe. And if additional lipid lowering is required, then we can add the bempedoic acid, and still there is a 20% more reduction is required. Then as already told by Makadia sir, inclisiran and other monoclonal antibody is very helpful. So low risk and moderate risk group, one can start with the lifestyle intervention and then add the statin in next step. But from the high risk group onward, at least the high intensity statin therapy will start with, and check the lipid profile at the end of 4 week and 8 week. Reassess the LDL goal FOB, and if target is not met, then you can add the ezetimibe, bempedoic acid, and PCSK9 in sequential mode. If any patient with myocardial infarction or stroke with the baseline LDL between 110 to 160, one can start with the two drugs therapy. If baseline LDL is more than 160 and patient having MI or stroke, one should start with the at least 3 drugs with combination of statin, ezetimibe, and bempedoic acid. If a patient is statin intolerance, then the option of combination of bempedoic acid and ezetimibe, and then switch to the inclisiran or PCSK9 inhibitor if further reduction is required. Algorithm for managing hypertriglyceridemia, as Solanki sir said, below 500 milligram our target is the LDL. First address the LDL with the ezetimibe and statin, and if further higher triglyceride level even after this, then we can add the icosapentaethyl or fibrate, but less weightage on fibrate, because reduced IT trial shows the mortality benefit in the icosapentaethyl only. And more than 500 milligram, you have to focus first the triglyceride and then the LDL cholesterol. Managing diabetic dyslipidemia, classified the patient in various risk categories, very important, otherwise management is similar. Diabetes without ASCVD, without any target organ damage, comes into high risk group. Diabetes with target organ damage or more or 2 ASCVD risk factor is classified into very high risk group. Those diabetes with already having a MI or stroke, means diabetes with ASCVD, they at least either in extreme risk category A or extreme risk category B, depend upon the other risk factor. So any diabetes patient ultimately directly fall into the either high risk, very high risk, extreme risk category A or extreme risk category B. So at least LDL cholesterol reduction less than 70 is recommended, depend upon the associated risk factor in every patient. Managing the dyslipidemia in ACS patient, guideline recommended to start at least with high intensity statin and ezetimibe in the all patient. Approach to risk category C. So despite of low LDL level, what we can do if the patient having another cardiovascular event, re-MI, or patient having recurrent stroke. So we have to address the residual risk factor like SGLT2 inhibitor, GLP-1 to address the residual metabolic risk factor, address the triglyceride with icosapentaethyl, address the residual inflammatory risk with the colchicine 0.5 milligram twice a day, optimize the antiplatelet therapy, or where there is a necessary antiplatelet with the rivaroxaban is a key to reduce the further risk, and ultimately PCSK9 inhibitor lower is a better. So residual risk and biomarker, one should go for the lipoprotein small a once in a lifetime. HSCRP considered as a risk enhancer. Use carotid intermedial thickness and coronary artery calcium score in a borderline case where there is a dilemma regarding whether to start the statin or not. You can identify subclinical atherosclerosis and go for further things. monitoring non-HDL and ApoB is better than rather than the considering LDL cholesterol only. So, in Indian population, lipoprotein A is higher than the other Western population. Lipoprotein A more than 50 directly put the patient in high risk category. ApoB reflect that entire atherogenic particle load, and it is stronger predictor than the LDL alone. Target the ApoB more than less than 65 in high risk, very high risk group, and less than 50 in a extreme risk category B. Elevated lipoprotein A or B should prompt the addition of ezetimibe and PCSK9 inhibitor earlier. As Solanki sir said, dietary restriction and physical activity is recommended, but there is no role of dietary supplement in recent trial even in ESC society. So thanks for patient listening.